Next, we're going to flip to page 1544 in your book and talk about patients experiencing lower back pain. Okay, on page 1544, we're just going to talk about lower back pain. It can be acute versus chronic. In reality, 80% of the American population will experience lower back pain at one time, and it's, you should know, very common in healthcare. A lot of different reasons people have back pain, and we're going to go over some of these reasons. How do we diagnose the issue, or what's the problem with lower back pain? Typically a history, trying to ascertain when it started and were they doing anything in particular and what were their signs and symptoms, and an exam that's looking for any type of neuromuscular involvement, neurosensory involvement, and loss or use of an extremity. As far as additional diagnosis, it's possible that the patient would need to have an x-ray or possibly have a CAT scan or an MRI of the affected area. When someone has lower back pain, it's always considered conservative management therapy is best, meaning that we place this individual on some type of analgesic, usually some type of muscle relaxant, encourage them to take their medications, and encourage them to not lay in bed, but to maintain a certain level of activity. We want to avoid prolonged bed rest. They found that this is not beneficial. Many patients do benefit from physical therapy for lower back pain because often it is musculoskeletal in nature, and strengthening the core muscles is beneficial. Along with physical therapy, they often teach them stretching exercises and how to properly use heat and cold, traction, and TENS units. If necessary, steroids can be injected into the level of the vertebrae where the back pain is occurring, and we encourage people to use obviously proper body mechanics, which are outlined on page 1546. If you guys happen to remember those or don't remember those, you can look at the prevention of back pain and also table 64.6, which gives us a teaching guide on the do's and the don'ts. Okay, let's look at the picture in your book on page 1548. It is a good picture. It shows us, first and foremost, the top one, a normal disc. You can see how much height there is for this disc. All right, so that's the normal. Then people develop what we call degenerative disc disease. This is a natural process, a natural aging process, one of those things that we have to look forward to. So what happens is you essentially lose disc height, okay? So the disc thins out, and it starts to, as we age, dry out and shrink. And then this results in the disc not being able to do its function, which is to act like a shock absorber. Sometimes what happens then is the disc will actually then leak out, and you can see this where it says bulging disc. It will actually leak out into the nucleus pulpus. Now it's still contained, but it's leaking out, and what the bulging disc does is it can often press on a nerve and then cause different types of pain. When it is not contained, it actually herniates. Then you can see what the difference is between the bulging disc and the herniated disc. Now the substance has actually leaked out. Okay? Additionally, what happens, or what can happen, is what we call degenerative disc disease with osteophyte formation, and that just means that now the vertebrae themselves, you can see that they change the shape, that they actually are no longer smooth, that they change shape because the disc itself is so narrow. And then, well, we'll get to, I believe I have a better picture of spinal stenosis in a couple of slides where there's an actual narrowing of the spinal cord, and that's kind of entrapping the actual spinal cord. Yes. So this picture is essentially the same as the one in your book, except for on the right you can see how the spinal cord has narrowed, and you can see how it's entrapped and how that would cause an inflammation. And essentially this press on nerve roots and the signs and symptoms, for instance, let's look at the bottom of page 1548, go along with the level that's involved. And so let's say you had the spinal stenosis at L5S1. Then these individuals typically have pain in their buttocks to the sole in their feet. And their motor function that can be impaired would be like their hamstring and the gluteus maximus. And a lot of times they have sensation changes in their heel and their lateral foot. Okay, so we've talked about the diagnostics, the treatments we've already talked about. So there's some surgical terms that we're going to keep this pretty simple. Your book goes into some very specific surgical interventions, but we're going to keep these pretty simple. So we have first the laminectomy. This is the traditional surgical procedure for when you have an issue with a lumbar disc, and we actually take out part of the vertebrae, okay? And when we do that, we can get or gain access to the disc that is protruding, such as in a herniated disc, and remove it. A discectomy would be that it's another common surgical procedure. We would remove the entire disc, and then this helps decompress or release the pressure that's on the actual nerve root. Okay? Sometimes for spinal stenosis, we actually need to widen or open up more the actual spinal cord canal, and this is called the foraminotomy. Sometimes when there is more than one level involved, we may have to do what we call a spinal fusion, and this is when a spine is unstable. And so we actually fuse different levels together using a bone graft, usually from the patient, but often it can also be cadaver bone. This often also involves some type of metal fixator device that is implanted into the patient's back. It could be rods, screws, plates. It just depends. So if we had a discectomy, a lot of times we're doing a decompression, and that means that we're just releasing the pressure that has been impinging upon the nerve roots that are involved at the particular sites. Okay, on this slide we're only going to talk about lumbar post-op care. Positioning wise, typically what we want to do is make sure that we place pillows under the thighs of each leg when in the supine position, and that when the legs are, or your patient's in your sideline position, that we provide a pillow in between their knees, and that we maintain proper body alignment, that if needed, we get sufficient staff to make sure we can maintain proper body alignment when turning them. We want to do good neurovascular checks. We've talked about the 6 Ps. You want to make sure that everything is intact. There's good movement of the legs. There's good sensation, and we're usually doing this every 2 to 4 hours. A wound, we want to watch the surgical incision site. For a lumbar, it could be an anterior incision. It's on the belly, or it could be posterior. You really do, though, want to make sure that it's not leaking CSF fluid. CSF fluid is clear, so how would we know? Well, one, the patient would develop a severe headache postoperatively. We would want to report that. And two, if we notice that the surgical dressing is, that the surgical site is draining and it's clear, we can actually test it for glucose. Use a glucose stick and test it, because CSF fluid does have a high concentration of glucose in it. We want to provide analgesics, often opioids at first. A lot of times muscle relaxants are also provided. As far as mobility, it's almost immediate for most of these surgeries, and they are typically instructed on how long they can sit, how long they can stand. So they have to be very cautious in sitting and standing. Complications, big ones, are a paralytic ileus, and so that's why it's important to get these people up and moving and making sure that they drink plenty of fluids and that we are giving them stool softeners. And also bladder infections or inadequate bladder emptying, so we want to make sure that we're monitoring this closely as well.